Hey, everybody, John Marshall with Oncology Update. Welcome back. This is episode 5. We now have a really cool function called Ask a Question. Click on that, send us something. We hope to get back with you with an answer. Most of the time, you see these things and it's all nailed down and you know exactly what you're about to get. Not so much with this. We're really trying to bring to you the current day's news, what's going on in our world, in the world of cancer, both in the science world, the social world, and the business world. And you know what? You just can't script that kind of stuff. It just happens as it happens. So a little bit of oncology unscripted. First, the news of the day, U.S. News and World Report just came out. Again, guess which one was the number one? Of course, it's MD Anderson, number one. Again, the top tier teams, it's like the Yankees going against the Dodgers. It's always the same teams year after year, but congratulations to that fabulous group down in Houston, Texas. We here at Georgetown are just pumped that we got our NCI renewal, our comprehensive status for a fresh 5 years. Always a good moment for an NCI Cancer Center, either to get it or to maintain it. So thank you, all the hard work that went into that. Big news out there. Friends of Cancer Research gave out their annual leadership awards. Monica Bertinoli, our new head out at the NCI, doing a fabulous job, as well as Brett Guthrie. So great people who well deserve the Friends of Cancer Research Leadership Award. So kudos to them. Just some business news out there. Lee Zing, who was a UT San Antonio person all along, just named the executive director of their fabulous Mays Cancer Center. Mark Burkhardt, he's a good human as well. University of Iowa just named him their new cancer center director. Was at University of Wisconsin, so moved kind of, I don't know, south a little bit. Still will be not such great weather, although Iowa's probably a little better weather than Wisconsin. We'll see how it goes there. So congratulations to that. On the clinical research front, some news that maybe doesn't really make it here to the US so much is that the EU, which has been doing a lot of our major clinical research lately, making up for some of the gaps that we certainly haven't been filling as well, but they've had a sort of sudden halt to clinical research because of some new regulations around devices and things one uses to test and measure stuff. So you can imagine scans and other things like that. So there's some new regulations there that has sort of thrown a monkey wrench into EU clinical research. And my guess is it may take them a bit of time to figure that out, but hopefully they will figure that out fast. The one piece of news that really caught my eye this cycle was not something you would see in your journals that hit your door, maybe not something you'd see in any of your feed. And this is from the Federal Trade Commission. So there was a Federal Trade Commission report that had to be voted on, and it's all about the anti-competitive harms of pharmacy benefit management industry, PBMs, pharmacy benefit managers, PBMs. And we know in the cancer world, these things have become huge. But on July 9th, not too long ago, the FTC voted 4-1, I'm reading this to not get it wrong, to release an interim staff report around pharmacy benefit managers, the powerful middlemen, inflating drug costs and squeezing Main Street pharmacies. You and I know this is going on out there. We're feeling it. Our patients, maybe not, interestingly, they're a little bit on the sideline about this because in the United States, we don't judge value around here. So this is going to kick off one in a series of the middlemen in our world. We are going to talk about CROs, clinical research organizations, certainly going to talk about electronic medical records. They're sort of our data middlemen. But for this episode, we're going to talk about pharmacy benefit managers. Now, benefit, I love that word. I get benefits from my job here at the university. It's in my benefits package. What these pharmacy benefit managers are taking advantage of is that that's money that I don't really feel, I don't really see. It's going to pay for things, and they're getting, of course, their cut. So we're going to try and drill down on this. Now, as we usually do, we did a pretty extensive literature run, and there are some papers here and there. There's a JCO paper, it's a little while ago, Lancet had one, but nothing really recent about the impact of PBMs on our medical world. So what we did is we went out and found a couple of really good experts that we're going to be interviewing. But let me talk a little bit about just these PBMs and the impact that they are having. So for example, a couple of or three of PBMs, or at least these are now big companies that are, of course, vertically integrated, but they've gotten so big that they're thinking about buying practices. And one of the practices that's out there being considered is Florida Cancer Specialists and Research Institute. Now, I know a lot of the people at Florida Cancer. It's a great healthcare system. The cancer community is outstanding. But McKesson and Syncora and Cardinal Health, not commenting, but there is suggestions that they're out trying to buy this organization. And they're worth about $3 billion out there in the open marketplace. And then what you could see is you've not only got, pharmacies and hospitals and all of that, but now you own the physicians as well in this. So that's going to be an interesting thing to watch out for, is that. But let me show you another sort of side mark of this. And this is this thing that I recently heard about called Lilly Direct. Now, Eli Lilly, right? They are solid company. They've been doing a lot. They've got a lot of innovative drugs that are out there, but they had something called Lilly Direct. And so I went onto their website. You should do this too. And what it is a website for patients who might not have a doctor or whose doctor might not be willing to prescribe a medicine that Lilly sells. There's some weight loss drugs in there, by the way. And you can click and it says, do you have a doctor or don't you? And if you don't, they give you one and you have a visit, I assume, with that doctor. But then Lilly mails you the drug. There is no in-between pharmacy. So now you're even being sidelined as a physician to where Lilly will be providing the physician through some mechanism, and then will be mailing you the drug directly to remove this middleman, a different kind of strategy to cut out that PBM and now your own pharmacy or your local pharmacy from that pathway as well. It'll be just coming direct from Lilly. Now, the big ones, of course, are CVS Caremark, Express Scripts, Optum Rx. Those three companies have nearly 80% of the market share. And of course, this is a subject of a recent House Oversight Committee review to look at that and see if there is any, is that clean? Is that what are the rules in there? Are we getting the best for our buck there? On the other end of the country, Blue Shield of California actually kicks out CVS Caremark as a PBM. And they basically are starting up their own new pharmacy model. So there's a lot of big moving parts in this space. Some of you out there are familiar with PBMs and all of this world. I was not when I started to get into this world a little bit more in my roles. And so there's a lot to learn, a lot to know. And I do think we represent an important voice in this process, not just victims of it, but part of it that we can influence some change. So I encourage you to listen to a couple of interviews that we did with people who are really smart about this subject. So you too can be a little smarter about it and maybe have some influence on this in your own way. So our first of our two interviews is Stacey McCullough. And Stacey's just amazing. She is the Chief Pharmacy Officer at Incoda. As I promised, I have got a world's expert on PBMs to come and join us. Now, I didn't know this person until pretty recently when I started working with a group called Incoda. They were silly enough to invite me to be part of their oversight group. And it's been an incredible eye-opening experience to me to understand so much more about this important aspect of the business of oncology. So with me shutting up, let me introduce Stacey McCullough. She is the Chief Pharmacy Officer of Incoda, and she is our sort of guru, if you will, of understanding what's going on out there in our oncology world and the impact specifically on access to drugs and the impact of PBM. So Stacey, first, let me thank you very, very much for, as usual, on short notice, being willing to jump in and share your thoughts on this important topic.
Dr. Marshall, happy to be here, and thank you for serving with us and bringing all your expertise to Incoda. It's a pleasure.
As I said, I've learned more from you than I've taught back the other direction. So I'm keeping going that direction. But here at our hospital system in Washington, D.C., I had no real PBM awareness until really more recently. I used to think of PBMs as maybe a good thing, as maybe a cost savings thing, a way to manage prescriptions on a higher level for patients who needed chronic prescriptions. But more recently, I've had actually now I think up to 4 episodes where I've tried to order a medicine for colorectal cancer for a patient on label, perfectly straight indication, where I was told I couldn't. I was trying to figure out who, in fact, told me I couldn't. And I couldn't get a peer-to-peer review, none of that. But I was told I had to order a different drug first before I could order the drug that I wanted to order. So now my recommendations were being dictated by some really, I don't know who out there telling me what I could do. And so my PBM awareness changed on a dime. So maybe if you could give us a little bit of background on all of this and how that could have gone from something that we thought of as good to something maybe not so good.
Yeah, absolutely. So I think what you reference is maybe the experience of a lot of people, and probably started a decade or so plus ago when, as you know, being a giant within the oncology space, we started going from infused products to oral products. So instead of, a buy and bill model, we introduced the pharmacy benefit. And what we saw in kind of that deluge of specialty products coming out, oncology led the way in that growth of specialty products. And so we saw pharmacies and PBMs start to compete, not just within specialty pharmacy, but with an eye on oncology specifically, because it was a leader among the fields. So PBMs integrated in 2018 or so, where the payer owned the PBM and the PBM had their own specialty pharmacy. And so probably that would have been the entree into your world more specifically, all of these new oral oncology drugs. And then in addition to that, specialty pharmacies, maybe within your institution, as well as specialty pharmacies that are owned by the plan and the PBMs now competing for the control of your patient from a pharmacy dispensing the drug perspective.
Yeah, we've been talking about being a middleman, but it's today. So it's a middle person in the chain of events. Often middle people add value to the chain, if you will. And I think that was the initial intention, is that this was going to be value added, maybe save some of our staff some time and effort, maybe speed the delivery of medicines. What's your take on the value added of the middleman of the PBM?
Yeah, so I think the value add, services offered. So ideally, the definition of a specialty pharmacy would be that you do prior authorizations, you help the patient find copay assistance, you utilize manufacturer copay cards. But really, every step in the process, your teams, you have an internal pharmacy there. And so your teams are set up to do that. They have access to the EMR. They can go in and get the patient information. So you've created your own efficiencies. I guess the benefit would be if you're asking for a benefit versus if you've already established the process and then it's an intrusion basically on your current workflows. And that latter case is probably what has happened with the PBMs. In that they then insert themselves between the physician and the patient oftentimes. The services that they offer may be difficult to offer without access to the EMR. So they're kind of offering, I guess, education as well as benefits that maybe are outside what you're aware of, often confusing to the patient because you introduce another party into their care. And then, your oversight really is lost a little bit. You don't know when the patient is getting their refills. If the patient calls the pharmacy to report a side effect or an issue with the medication, how does that get back to you? So all well intended potentially, but now the complexity of oncology care definitely an impediment a lot of times to the care versus the benefit.
Yeah. I mean, there's a lot of money involved. I mean, here in Washington, we get ads about PBMs on bus stops and on the morning news. So it's obviously an important political issue as well about how this is going to go. What's your take, or maybe what's in CODA's take on, how this should evolve, or what the recommendations are to improve this process further? Because the orals are not going to go away. They're going to only increase. So we need to figure this out.
Sure. I mean, the the complexity of oncology care in itself is enough. So fragmentation of care should be avoided. The pharmacies that are in your institution, the medically integrated pharmacies, there's accreditations for specialty pharmacies out there, and CODA has an accreditation as well. These accreditations are intended to ensure operational as well as patient care. So, with those accreditations, that is the establishment, if you will, of good, sound practices.
Mhm.
That should buy a pharmacy access to dispense these medications. Basically, what you're showing is that you're helping patients get access, you're making it affordable, and you're able to manage the patient from a side effect educational profile. So outside of having that in every pharmacy kind of showing those competencies, specialty pharmacies mandating that it go to their mail order pharmacy or it go to their specialty pharmacy is really without validation. There's no reason other than the economic benefit, as you mentioned in that. So, we support the continuity of care. We support the physician being the overseer of all of the care and the medically integrated team so that when you prescribe a medication, you have expectations of what your pharmacy team is going to do. You know that that patient is going to get access to the medication. It's going to be affordable. It's going to be dispensed. They're going to be educated in it. They're going to have tools that are going to empower them to be adherent with the medication. And any glitches in any of those steps in the process, you're going to get a notification back through your EMR to let you know that. Outside pharmacies aren't able to do that. And so, what goes on then outside of that, not only are they not able to promote optimal care, but some of the actions that they take may actually derail the care, such as you mentioned, in that, you chose a product for a patient and an outside entity tells you that you need to choose a different product. Typically, we all know these are very expensive products, as you mentioned. List price are about the same. And so, why the choice of one agent over another? I think, even within a class of medication, distinct side effect profiles, and your experience and your conversation with the patient to understand what's going to be the better choice. Anybody coming in and inserting themselves without knowing that conversation is really outside the benefit of the patient.
Yeah. And dictating a therapy based on a price they got, not on the medical recommendation you're giving.
Well, and you bring up one other good point that we hadn't talked about, and that is the difference in buy and bill on the pharmacy side. Buy and bill, you get the bill on the back side. At the pharmacy, you pay at the register before you get your prescription. So any of these price concessions that are on the back end, the patient is often paying a higher price because they're paying it off that list price, not off the net price, sans any of the rebates or discounts that are in that. So that bubble pricing effect really does impact the patient often as well.
And of course, no transparency to that. You would never know what actually happened behind the scenes on all of that, right?
Absolutely. And that's where, the resources that manufacturers often put out to help the patients, the copay, the patient assistance programs. We've seen, copay maximizers and copay accumulators that redirect that benefit from the patient, back to the PBM. We've seen alternative funding models and that, patients are effectively uninsured because the preferred drug list is non existent. And so that actually qualifies them for manufacturer copay assistance or patient assistance programs, even though they're paying for insurance. So there's no transparency, but the level of deception is very high within that too. And so patients are often caught in the middle of that, and you as their prescriber trying to get them medication. That's the downside.
Stacey McCullough, Chief Pharmacy Officer at Encoda. As I promised you all out there, she knows what the heck she's talking about, and the vision going forward of what we need to do, what we need to make sure and emphasize as practicing physicians and all of us in this business of oncology. We need to figure out and evolve this PBM process further so it's in the best interest of our patients. So Stacey, again, thank you so much for joining us.
Dr. Marshall, always a pleasure to see you.
That was amazing. I hope you agree that Stacey's insights and thoughts about how we need to move this stuff forward is really useful to us. But we actually got also a second interview and a second sort of take on this. I do want to introduce you to Antonio Ciaccia. Antonio founded several things along the way. He works at a place called 3-Axis Advisors. It spends their day thinking about this issue of pharmaceuticals in the United States and ways that we could evolve it so that not only is there more transparency, there's more access and improved market system in place for all of us. So I am pleased to introduce Antonio Ciaccia. Antonio, welcome.
I study drug prices for a living. We track manufacturer price changes. We track Medicare expenditures, Medicaid expenditures. We look at publicly available data sets that demonstrate utilization and pricing trends. And what we have learned over time is that between those moments of money going in and money squeezing out, there is a lot being lost in translation.
Okay, if that's the problem, where do we go?
Well, in a number of directions. First and foremost, I think everybody believes that we should move toward a system of value-based medicine.
Yeah.
I'm a big believer in the philosophy of value-based payments and value-based medicine. Problem is that the architecture of our system today is not aligned in that direction. We buy medicines based on volume, not value. The bigger you are, the bigger discounts you achieve. Thus, typically, the greater financial rewards you will yield. Everything I said there has nothing to do with the quality of the service rendered, the outcome to the patient, et cetera. The key driver of volume-based payments and volume-based reimbursement starts with our exemptions to federal anti-kickback laws that allows PBMs and health insurance companies to collect big kickbacks from drug companies in exchange for preferential treatment on the formularies. Those exemptions create an arms race to become larger and larger, thus to extract larger and larger kickbacks, which results in significant market concentration and also insulates drug companies from the traditional competitive forces of lowering prices. Instead, in competitive environments, they compete to raise prices to create more bandwidth for kickbacks, which increases our reliance on the intermediaries to negotiate our way out of the problem.
Do you see us ever getting to a value-based? I've spoken for years on this subject because I've lived it 32 years as an oncologist. I've watched this business evolve. And I regularly say, like, would you swipe your own Visa card? Maybe I should say now, tap your own Visa card for it. And then because that would say, all right, well, let's connect the magnitude of benefit with the cost. And I can decide value-based medicine as a consumer. But because the consumer is in essence removed from the formula, they're not able to judge value ever.
The consumer has no meaningful impact on the business practices of the healthcare delivery system as it stands today. Mm-hmm. In general, decisions are made for them. And as a result, those who provide goods and services in our healthcare delivery system, they calibrate their business model and their offerings in the direction of the desires of the payers, not necessarily the origin of the payment, which is the individual patient. And Yeah, a good example you could see in pharmacy. Pharmacies don't compete to lower prices. Pharmacies don't often compete to increase their staffing to attract a patient to come there. Instead, the PBM decides where you'll go, right? And if they don't have complete carte blanche to decide where you'll go, they can heavily influence through cost sharing, pressure, you name it, where you ultimately go. I know pharmacies that have very low prices. And here in Columbus, Ohio, we have a pharmacy called Freedom Pharmacy. They don't accept insurance. Their prices are a fraction of what any other pharmacy offers. Mark Cuban's Cost Plus Drug Company, his list prices, his sticker prices, meaning the prices that are offered to everybody, are a fraction of what you'll find at other pharmacies. It begs a question that if the people that we hired to get us out of this drug pricing mess really had our interests at heart, they would be crawling over one another to get those pharmacies to be not only a network, but preferred. The opposite happens, right? They don't want them in network because they mess up the math. Instead, PBMs incentivize higher and higher usual and customary prices charged by pharmacies, and they negotiate big discounts off of those bogus inflated prices. The challenge, though, is that because of the way that PBMs contract with pharmacies, they actually incentivize them to charge higher and higher prices over time because of the disparate way that they pay them in the most favored nations clauses in their contracts, et cetera, which I don't need to bore you with, but trust my shorthand that PBMs incentivize pharmacies to charge higher and higher sticker prices. And so what that leaves us with is greater necessity to use the PBM to put out the very fire that they're partially responsible for creating. And so what is our way out of it? Well, our way out of it is having a system that actually incentivizes drug companies and pharmacies to lower their actual prices to increase the quality of their goods and services, rather than the opposite, which is getting bigger and bigger discounts off of increasingly inflated prices without any sort of quantification of value for the actual service that's being rendered by the provider or the quality of the product that is being offered by competing drug companies.
So let me ask one more angle on this, is that from the work that you all are doing, one of the principles that we've been talking about is lack of transparency. So if you're going to then report to a government or to a whatever that's asking for this information, how do you find it? Where is it?
I often complain about the lack of transparency in this marketplace, and be clear, there is not enough. However, relative to other forms of or other types of things that we buy in healthcare, pharmacy is relatively very transparent.
Mm-hmm.
My introduction into this world in a formal drug pricing research capacity was in my home state of Ohio. Pharmacies in our state were complaining about underpayments within our Medicaid managed care program. PBMs were driving lower and lower rates of reimbursement that was causing a lot of pharmacies to go out of business. Meanwhile, on the other end of the transaction, the state of Ohio said, we're spending more for medicines, and those two things didn't make sense. How could pharmacies be getting paid less? How could the state be getting charged more when they're ultimately involved in the same transactions? Well, what we started doing was downloading very boring Excel files off of CMS's website. One being the national average drug acquisition cost, which for those that don't know, is a benchmark that is provided by the Centers for Medicare and Medicaid Services, where they survey pharmacies on a month-by-month basis, and they simply ask them the question, what did you pay to put the drugs on the shelf? And so we took that data set and combined it with another data set called state drug utilization data, which is a quarter-by-quarter, state-by-state, drug-by-drug accounting of how much every Medicaid program is buying and for how much they pay for those drugs. And so we were able to stitch those two data sets together, one being the real cost of the drug as purchased by pharmacies, the second being what Ohio Medicaid and every other Medicaid program across the country was being charged. And what you saw was this divergent experience over time. Well, we took all that information and gave it to state officials at the time who I felt didn't do what I thought they should do with that information. And so I turned it over to local reporters. I sat down with reporters at the Columbus Dispatch. I flew out to New York to meet with folks at Bloomberg News. And I gave them all this data. And they said, we think there's a big story here. The state of Ohio eventually followed the trail. Our state auditor, Dave Yost, decided to open the books. And voila, they found that there were $245 million worth of hidden PBM spreads where they were buying low, paying the pharmacies very low, billing the state high, and pocketing the difference. All of that was started thanks to the accessibility and availability of limited, imperfect, but very valuable drug pricing data. What we have learned since then is that there's even more data out there. Medicare Part D has a ton of pricing information available on its site. You have folks like Mark Cuban that are publishing their prices. Costco publishes their prices. Before you know it, yeah, we have a black box in drug pricing, right? But the beauty of a black box is that it's multi-sided and there's a lot of things that you could find around it, right? Yeah. And so in answer to your question, there's not enough transparency, certainly. And I would argue that when we do work on behalf of state agencies or employers, they're not given the itemized receipt that they deserve. However, the limited amounts of transparency into the system we do have often helps us uncover the latest and greatest drug pricing schemes that are being cooked up by the various intermediaries in the drug supply chain.
You've done a great job of pulling this together and really serving the community at large, because the money that we're talking about is not really, I mean, whether it's government money or insurance company money or whatever, it's our money, right? This was money that we paid into these banks, these quote unquote banks, for them to then distribute and cover this. And so there couldn't be, honestly, a more important way to try and make our healthcare system more efficient and find the fat in it so that we can deliver more services. I mean, it's just crazy how much we spend and still how much we're limited by what we can do.
Let me depress you just one little more bit.
Go for it.
As an oncologist, our story is very relevant to your line of work. So the very first report that we ever issued was in August of 2018, when we launched 46 Brooklyn Research as a nonprofit dedicated to what I would call drug pricing journalism. The very first report we released was called The Cancerous Design of the U.S. Drug Pricing System. Mm-hmm. And it was all about generic Gleevec, okay? Which I would argue is the poster child for drug pricing dysfunction. It was a huge part of the Federal Trade Commission's report that was released within the last month. But basically what we found was that Medicaid programs across the country were getting charged thousands of dollars for something that had been declining in its underlying cost significantly over the last few years. Fast forward the tape, and again, this shows you the value of drug pricing transparency. We still see to this day Medicaid programs being charged thousands of dollars per prescription for generic Gleevec. We see employers being charged thousands of dollars per prescription. Patients in those commercial programs having cost sharing based upon those bloated prices. We just released a report in July where we were looking at pricing information for generic Gleevec in the Medicare Part D program. And the beauty of the Medicare program is that they will show you the prices of every single Medicare Part D plan. Mm-hmm. And within those Medicare formulary and pricing files, you can see it within every plan, the parent organization of those plans. As you well know, PBMs aren't really PBMs anymore. They're part of large vertically integrated companies that are often health insurers. Well, if you take all the prescriptions for generic Gleevec across all the different Medicare plans and roll them up to their parent organization, what you'll see is a company like CVS Health, which has hundreds of Medicare Part D plans. Despite the fact that this drug has been generic for a long time and is very cheap, still to this day, you will find CVS Health Medicare plans setting 597 different prices across all of its plans. The lowest price is around $2,600 per claim. The highest price is $8,200 per prescription, okay? Now, to give context here, not only do you have 597 prices, not only do you have about a $5,500 difference between the lowest price that they offer and the highest, that drug can be bought from Costco or Mark Cuban for less than $40.
Yeah.
Okay. So the games that we find, right, are not limited to that drug, but it is a demonstration of, I think, how much risk there is when there is not an aligned approach for how the prices of medicines are set at the pharmacy counter, and when there are raging conflicts of interest within the companies that are setting those prices.
Are we the only country that does this?
We are the only country that does this. Other countries have a much more heavy-handed approach to drug availability and pricing. They say, look, these are the drugs we're going to have in, and these are the prices they're going to be. Sometimes that means that they cut out a lot of the inefficiencies that our system has. In other ways, they disincentivize manufacturers from bringing certain products into those marketplaces.
Yeah.
That's a double-edged sword, and those are policy trade-offs that I think everybody has to consider. I personally am not as much of a fan of that heavy-handed approach because I think sometimes it can throw cold water on the access to medicines in the innovative churn that we rely upon to get access to those medicines. But regardless, I think the U.S. system hasn't been given a chance to flourish the way that a traditional market-based approach could, because we have all of these special rules for Medicaid rebates, 340B rebates. We have these GPOs and exemptions to kickback laws. We have all these things that make the U.S. marketplace special, aside from the price controls that separate, us on paper. I think that the U.S. marketplace can be materially different than what it is today without having to go all the way and say, hey, we just need to take this over at a government level.
So the free market could handle it if really it was a free market. And when I hear in the spectrum of sort of, government heavy, quote unquote, socialized medicine, you're not really there because of the level of restriction. But, I think about the British healthcare system and the NICE committees that oversee new drugs or new therapies, and they put a value proposition to it. So they say, okay, here's what you're going to charge for it. Here's the magnitude of benefit. Medical people make a judgment. They have a certain fixed amount of taxes they can spend on healthcare, and they make a decision in or out. So they actually, and then publish the data, the decision in Lancet, for example. But that's often criticized because there's a lot you can't get in Great Britain because of that public health service system. We can get it all, but it's a very disrupted system, as you say.
I think it's important to remember that there was a market-based system before PBMs, right?
Yeah.
And certainly it was not nearly as robust as it is today. But it is important to remember that there was a time where our wallets and purses are what guided this marketplace. And if a medicine was too expensive, we sought alternatives. If a pharmacy was too expensive, we sought alternatives. The second that third-party payment governed the marketplace, all right, that's when things really start to get out of whack. And that's not me saying we don't need third-party payment at all. It's not me saying that we should go back to a system where people can't afford their medicines. But I think it's important to understand that the traditional forces that we rely upon in a free market are not present in the environment we have today for medicine.
This has been perfect.
Have a good one.
I hope you all watched both of those interviews. I learned so much from both of those people about our world. Every time I click on an order in my EMR and send that prescription off into the ether somewhere, how many people are touching it? How many people are skimming a little money off of it? How many people are valuable in the process? How many people are unnecessary to the process and just making a dime off of this game that we play? It is so important that we fix this. Our patients are literally dying for better treatments and new treatments. Our industry partners are spending great resources on developing new therapies, most of which today are going to be oral therapies. And so we have to fix this. We have to fix it for progress. We have to fix it for our national, frankly, security. We have to make this cost less. We have to make it have the value that it really has, so that the money we're spending is going to the appropriate cures for cancer. And, the reason we want to do this is that the next time you see a patient with, say metastatic cancer, you say, stage 4 metastatic cancer, don't worry about that, because we can cure that.